Okay, thank you very much. Merci beaucoup à tout le monde pour m'inviter aujourd'hui pour l'organisation. I will speak in English as well. My meager attempts. Everybody keeps asking me if robots are going to replace humans in the workplace. And it's a good question. The answer is yes and no. To a large extent, they already have. So this is the cover of the September issue of the Atlantic Monthly, and there's an article in there called entitled "The End of Work." And the central thesis of the article was that 90% of all jobs that are currently done by humans can be done by machines, can be done automated. And this is from the most simple clerical tasks to the most complex, including building cars, which already has been happening for a long time, as well as driving them. I think surgery is at its core a fundamentally human endeavor. It requires the most complex executive functions that human beings are capable of. And while it's exciting to think about robots doing surgery, in reality, humans do surgery controlling a sophisticated instrument, which is a robot. The Da Vinci, of course, is the first in man of such a machine. And it is very much an instrument. It's controlled by the human hand and the human mind. But it's a special instrument. So what makes it different than, for instance, like a needle driver is that it can, the degree to which it can enhance human capability, superhuman precision, motion scaling, terminal lineation, high resolution 3D optics, and of course it can go where human beings can't go. And that makes it a substantially sophisticated instrument. And because of the sophistication, it's sort of dominated minimally invasive surgery in many of the subspecialties at this point. It's a latecomer to my subspecialty, but hopefully here to stay. So I think what we've often tried to emphasize in this meeting, and what I always continue to try to emphasize, is even though these machines are sophisticated to us, they're still very immature. And I think that they are analogous to the computers that were first built, which filled a room and really could barely perform any tasks. And I think the future versions of these machines are going to be like the present versions of our computers. They're going to be sleeker, they're going to be faster, they're going to have more invisible human interfaces. So I think it's important as we go through and talk about not just what we currently do, but what it is possible to do, because I think that's what this meeting has always tried to be about. So I'm just going to spend the next few minutes talking about what I do in plastic surgery with robotics. It's a good first day talk because I go all over the body with this, and so you can sort of see the various things that are possible. Robotic muscle harvest, which allows the harvest of muscles with really minimal incisions. Robotic microsurgery, which provides, as we'll see, precision beyond human capabilities in most cases. And transoral robotic reconstruction, we've already seen some of that, which provides access to deep anatomy without splitting the mandible. So let's start with the latissimus harvest. The conventional incision for the harvest of this muscle is long. It's a fairly morbid incision. The scar is ugly, and most complications of the surgery are related to the scar. So I've developed this technique to take it out through a small axillary incision, a couple of ports, and insufflation. This is the location of the ports in the incision. I put one of the ports in the incision if I use that incision. The incision is to dissect the anterior portion of the muscle to create an optical window. All the instruments have to be in a confluent space, and so that's an important part of this. And also to dissect and control the pedicle. So we then sew that incision back up, put a port in it, and get insufflation. I dissect and sew up the edge of the muscle so that I can dissect under the muscle first. We then dock the machine. It's a dual console system, so you can swap instruments back and forth. You can use this as a teaching device. This is what it looks like outside the body. So you can see where normally you would have surgeons working directly on the patient. Here, the assistants sit by and watch, and what's going on inside the body is here on the vision tower. And then this is what's happening inside. So the way that I approach this is I first dissect the underside of the muscle. And that's important because if you try to do the superficial surface first, the insufflation will just press it down onto the chest wall, and you won't be able to actually elevate it. You can see the control of small blood vessels. It's very precise. There's very minimal bleeding. After you dissect the deep surface, then you come over the top of the muscle. The The one technical modification I made recently is I do a lot more of this dissection open. I do about 2/3 of the dissection open through the axilla, and then just do the additional third that I don't have access to using insufflation. So you come all the way over the superficial surface of the muscle till you get to the thoracolumbar fascia on the other side by the spine, and then basically just come up and around the backside and just disinsert it. It should be a very gossamer, a very thin insertion at that point. There's a vessel loop there around the pedicle. I don't do that anymore. I just stay completely away from it. It's not necessary actually to even get near it. And now I'm just doing that posterior dissection part that we discussed and rolling the entire muscle up into the axilla. Another technical modification I've made is I dissect the upper border of the scapula a little bit first, and then I connect those into incisions, because moving the entire muscle up into the axilla is just difficult to do in that confined space. But you can do the entire thing through a very small incision and take the whole muscle out. And I use this for a couple of different indications. As a free flap for the non-plastic surgeons, that means you disconnect the entire thing, you reconnect it somewhere else with the avasculature. And then I use it as a pedicle flap for chest wall reconstruction and for a variety of breast applications that probably go beyond the scope of what we're talking about here. But just some case examples of this: free flap for scalp reconstruction, this composite defect of the scalp, which will be radiated because of perineural invasion. And so we usually like to put a free flap on this. So this is the markings, the setup, the harvest, and then to answer the question from neurosurgery, that this is anastomose of the superficial temporal vessels. We use them relatively frequently. They're often reliable, but occasionally not. The vein can be small. And then this is what they look like after radiation. They heal up very well. This is not unique to robotic microsurgery, but this is. There's no back incision, so that's quite nice for the patients. In breast reconstruction, cosmetics is even more important, and so the lack of a back incision is important. I call this an incisionless harvest because the entire thing is done actually through the mastectomy incision. There's no axillary incision anymore for this. And so in certain cases, like this is a radiated case, you can bring the entire muscle in and put it over an implant. Functions very well, protects radiated skin very well. You're not going to do a abdominal-based free flap. And this is a patient who's gotten severe radiation injury and gets a total capsulectomy, and then the muscle put in, which will keep that reconstruction nice and soft. This can also be used for very thin mastectomy flaps in a patient for like a nipple areolar complex mastectomy. Here she is pre-op, here she is after the latissimus and an implant, and then after stage 2 with a contralateral augmentation. And this is, remember, this is breast reconstruction. This is not cosmetic breast surgery. So the results are good for what we normally get. And again, no back incision. So this is what a latissimus scar usually looks like. So that's a substantial improvement. And again, this is just another patient, similar thing, pre-op, after stage 1, after stage 2. So we've described this technique in detail, and you can, we'll have some probably more technical modifications to see. I'm not going to talk about this procedure too much because I think John is up next and he's going to talk more about this, but traditional incision for the rectus abdominis muscle harvest is again a long incision to get the muscle out. John and others have developed this intraperitoneal approach, so this is very different from the approach we usually use. I'm not going to talk too much about this because John will approach it, but we also take it out through a laparoscopic retrieval bag, so there isn't the additional retrieval incision anymore. So the pore placement is lateral on the contralateral side to the muscle that's being harvested, and this is what this looks like. So the first thing to do is to make an incision quite close to the midline, close to the insertion, and then you have to find the medial border of the muscle. So this is the most difficult part because you're basically looking sort of straight up at the midline. As you get further down the horizon line, the operative approach gets simpler. But you dissect the entire thing off the anterior fascia, leave the anterior fascia completely intact, which is the opposite of what we normally do. You can dissect the pedicle very easily. This is the deep inferior epigastric vessels, which supply this muscle. And then you can complete the disinsertion from the pubis, and then just come up the sides and take off the lateral insertion, and then finally from the costal margin here. And this can be used again as a free flap or a pedicle flap. If it's used as a free flap, you can go in with a wet clip, which is a robotic instrument, and just put it across the pedicle. Make sure you check that you're all the way across, because or else you have to open up for fairly aggressive bleeding. And then you just take the whole thing out. And so this is what these pictures are from our article with John. These are the ports. We used this incision to take it out. I've eliminated that. Now I just put a laparoscopic retrieval bag right through one of the 12 ports and pull the whole thing out with that. And the donor site is quite nice. This is a laparotomy, normal laparotomy for these types of things. So the indications for this, again, you can use this as a free flap for scalp and extremity, which means you transfer it out of the abdomen, put it somewhere else. What I'm finding the most use for this for in the cancer center that I work in is in conjunction with other robotic intra-abdominal procedures. There may be multiple services involved, and rather than the plastic surgeon being the one to create a laparotomy to do a reconstruction when 5 different services have gone to great lengths to maintain a minimally invasive approach, we can also keep pace with them and do our reconstruction without a laparotomy, and that's important for a multi-team approach like this. And John and I have written this up and described the technique as well. So robotic microsurgery, this is sort of the premise of the meeting, and everything else is kind of an offshoot of that. But the history of the microanastomosis is pretty short. In 1902, Alexis Carrel developed the technique of end-to-end anastomosis. He got the Nobel Prize for this in 1919. In 1960, Jules Jacobson described and developed the operating microscope. And since then, really, there's been almost nothing. A couple of needle modifications, some micro instruments were made. But in the meantime, the technical demands for microsurgery have increased dramatically. We now have super microsurgery, as Yelena described this morning. We have perforator anastomosis that people are advocating, lymphatic anastomoses, which are quite torturous. So why do this? It's painful, isn't it? It's painful to watch. So, this is a fully trained plastic surgeon working on, a rat vessel, and this is humanity. This is what we are. Some of us are better than others, but we all have limits. So this is a robotic microanastomosis done with a silastic vessel. But I think it's pretty self-evident that there's a big difference, at least in the ends of the spectrum, between very good and not so good. And I think many of us believe that because of that difference, that this is probably going to end up being the direction that microsurgery goes. So that's kind of the basics of where we are with that. And I think for me, this has always been as much theoretically strong as it has not taken off yet in practice, which is, the robots are capable of superhuman precision. Microsurgery requires a high level of precision, and so robots should be good for microsurgery. And whether the current incarnation of machines are the right machines or whether there are other machines, these principles are universal principles, and so that's just something that I think will hold. So, case example, head and neck, this is oropharyngeal cancer, so this is a total laryngectomy. This is the defect, this is the specimen. We usually use 2 flaps for this. The ALT was mentioned, so we get 2 perforators. We tube one of the portions to reconstruct the pharyngoesophagus, and we use another portion for the external skin paddle. And we tube this on the thigh, and then this is the pedicle. So these are the vessels that we ultimately connect. This is the setup of the neck. These are the vessels here. These are the robotic instruments and the camera. And so this is what a live robotic microanastomosis looks like. This is double speed, just in case you thought this was like a rabbit heart. So I think there's some advantages and disadvantages to doing robotic microsurgery. The main advantage is precision. So the robot in its current form is capable of 5-to-1 motion scaling. That means if you move 5 centimeters, the machine moves 1 centimeter. It has 100% tremor elimination, which we've already talked about. And so those account for a very high level of precision. There are ergonomic issues as well and access issues, which I think benefit. The main disadvantages that have been cited are the lack of haptic feedback, As was discussed earlier, I think this is less of a concern than people make it seem to be. I think a lot of what we think we feel, our brains are supplying the illusion of sensation. We're really picking up visual cues, but the point was taken that the pop through the vessel you can feel, and so, but you can also see it. And so it's something that you have to learn to recognize visually. The other issues have to do with instrumentation and optics, and we'll talk about that as well. So super microsurgery, this is particularly interesting to me with respect to robotics, because this is what pushes or exceeds the limits of human capabilities. And I was trying to push Elena this morning to say what I believe, which is that the real barrier for people being able to take a leap from doing like internal mammary vessels, which are big, to lymphatic vessels is really our own physiology. You know, that our physiologic tremor at 25 magnification is high. And so this is where I think it gets interesting. So just to show you a case example, we do lymphovenous bypass for lymphedema. This connects lymphatics to veins to reroute the lymphatics through the tissue. So we inject indocyanine green, which laser fluoresces under angiography, or fluoresces under laser angiography. So just to give you an idea of the scale, Elena talked about it, but these things are really small. So, you know, these squares are 1 millimeter. So we're talking about half a millimeter, less than half a millimeter sometimes. So this just shows the laser angiography to identify the dermal lymphatics. Once we identify those, we identify a vein. I think you can see immediately that this is much different than the other anastomosis. The instruments look huge. They're not huge, they're the same instruments. The vessels are very small. So the intraluminal diameter of the vein is probably half a millimeter, and the intraluminal diameter of the lymphatic is probably 0.3 millimeters. These are really small. So I know you guys aren't used to looking at this, but normally when you're trying to do this under 25x, your movement is dramatic. So this is a hand, and this is my fellow trying to cut the suture. And so I have to do a little robotic assistance here to help him out. But I mean, it really does show the difference between you know, the human hand and the robotic instrumentation. So I think the main problem here is these instruments obviously are way too big. I mean, 5 orders of magnitude too large, and the optics are not good enough. So we're at 10x here, fixed distance endoscope with medium resolution. We want to be up at around 25x, so we can really see that lumen very well. So you might say, well, okay, this is gimmicky, you know, not everybody can do it. You can do it, CJO can do it, but what about the rest of the world? I'm not going to go into this too much because Dr. Albershi is going to talk about this as well. But this is measurable, and this is very learnable, and it's learnable by expert microsurgeons, and it's also learnable by medical students who pick up the robot for the first time. And I won't go through all the data because she's going to go through it, but the bottom line is proficiency and efficiency in robotic microsurgical skill can be achieved by pretty much anyone in a fairly rapid period of time. And in fact, we've studied conventional microsurgery skill acquisition, and higher scores are achieved more quickly in robotic microsurgical skill than in conventional microsurgery, simply because there is this issue of human skill. And so we've published on both of these issues, both conventional and robotic microsurgery skills assessment. We've compared those things. So just the last thing I want to touch on briefly, we've already discussed, is transoral robotic surgery. You know, access to oropharyngeal cancers has traditionally been through a wide transmandibular approach. There's obviously, you can see from the picture, a lot of aesthetic and thus functional morbidity from this. And really, because of that, a paradigm shifted away from this to definitive chemoradiation therapy for these, but the long-term effects of that has been fairly severe morbidity as well, including laryngeal dysfunction and chronic aspiration. And so that hasn't been the greatest answer either. So transoral robotic surgery kind of sits at the sweet spot here because it provides local regional surgical control. It can avoid facial incisions, it can avoid mandibulotomies, which have a lot of problems, and it can reduce and even sometimes eliminate the need for radiation in these cases, which is fairly morbid. So the reconstructive challenge is in these cases the cylinder of the oropharynx remains closed, and so the access to this anatomy is very restricted, as was discussed, particularly between the area between the uvula and the epiglottis, which is quite hard to get to. So the best way to show this is just through a case example. This is a patient with a squamous cell carcinoma, the glossopharyngeal sulcus sitting here. And so this happens to be an ulnar artery perforator flap. This is the ulnar nerve here, and this is just the tissue on its pedicle. We put this in the mouth, put the robot in the mouth, and then inset this. And this isn't much different than what you've seen before. This is a cleft palate view, so the palate's up here, this is the tongue, and then these are the teeth over here. And I think the advantages of this are really visualization and precision. And these are important because if you have too much redundant tissue here, it's going to impede future speech and swallowing. And if you don't get perfect tissue-to-tissue apposition, you get a pharyngocutaneous or an orocutaneous fistula, which can be very morbid. It's basically saliva leaking into the neck that causes an infection. And so what was said is true, is that the ergonomics of suturing in the mouth can be kind of difficult. Small movements in the mouth correspond to relatively larger movements more proximally. And here the excursion of the arms is limited by the area within the mouth retractor, so you can kind of bang the teeth around, and the anesthesiologists don't like it. So you have to be a little bit careful. But generally speaking, this is a fairly good application for the robot as well. And I think the benefits of not dividing the mandible are many, cosmetic, but also functional as well. We've talked quite a bit about this. In my personal opinion, I don't do pediatric cleft surgery, but I think the future of this is in cleft surgery and in velopharyngeal dysfunction, where small flaps are raised in the posterior part of an extremely small oral cavity. And I think that the robot will be very well suited to that. So this is what I'm doing now. I don't have this totally cooked, but robotic mastectomy is something I've been thinking about for a while. Mastectomy techniques have gotten better and better. They are still having trouble doing a very good nipple-sparing mastectomy through standard incisions, which are short. This is a 6-centimeter incision and 2 additional ports. And this was a very large breast on a cadaver. You can see this is done by transillumination, and the planes are very recognizable. The only difficult one is the subareolar plane, which can be a little sticky. We can take out a very large breast all on block, and you can even take out the lymph nodes through this approach as well. So I think this has a lot of legs, and I think you're going to see more of this in the future. So speaking of the future, what are we going to see? I think, is all plastic surgery going to is all surgery going to become robotic? No. Hang on, not yet. I don't think so. I think you're going to see many more though procedures convert to robotic surgery. We're going to see rapid improvements in robotic technology, and that includes instruments, it includes optics, processing speed, interface. We're going to see a lot of augmented reality, especially in the neurosurgery world. You're going to see, we talked about this morning, automated robotic activity, which is autonomous. You're going to see small versions of that in specific areas, and hopefully we're going to see some microsurgical robots coming up. I think remote surgery is something that has been vastly underutilized. It allows us to take advantages of centers of excellence in ways we haven't yet. CJO has started to, I think, flirt with this, but I think the end result of what his process improvement and efficiency and multiple sites is going to be is that he's going to be able to do this without physically being present. I think that's going to be great. And then I think in general, we're going to see with robotics what we've seen in all technology really, which is that the cost is going to drop precipitously, the technology is going to improve precipitously, and really it's a matter of us to push this, but if we just waited, it would still happen. They'll get smaller, they'll get faster, and they'll get better. And of course cheaper, which is very important. So with that, I will leave you with, this picture froze. This is unfortunate because these are robotic musicians. Oh well, next time. Anyway, thank you very much for your attention, and I'll take any questions.